All right. Well, thank you all for joining us. Just a quick couple of notes, some housekeeping for you. We are recording this, and a recording of this webinar will be sent out to everyone who's registered. So thank you for joining us, first of all, and please be looking for that email in the next couple days. We'll be sending it out with the video for you to watch. We have the chat going. We encourage you to use the chat, but please submit questions in the Q&A section. There should be a little box at the bottom of your screen with a little Q&A question mark in there. If you click that, it'll help us find questions. We are going to have a live Q&A section at the end. Feel free to drop them in throughout the presentation, but we want to make sure that helps us make it easier to delineate between the Q&A and the chat. So please put those there. Okay, next slide. All right, so most of you probably know, but we recently had a rebrand almost a year ago now. We were Smart Denture Conversions, but we are now Smart on X. So if you're wondering who's Smart on X, it's the same company, it's the same people, same ownership. We just had to change our overarching brand to accommodate new product lines. You've probably heard about the Omnibut at this point. So things like the Omnibut and some of the things we'll even be discussing tonight, it made it, Smart on X made it possible for us to do all of those things. So same company, same people, just new name. All right, so here are the people who you're going to really be hearing from tonight. It's not going to be me. My name is Cameron Lanier, by the way. I'm the Director of Marketing at Smart on X. But you're going to be hearing a lot from Dr. Kofford here. And he's got a very impressive resume, as you can see here. But if you see Dr. Safa's resume, I don't want to say it's more impressive, but anywho, we appreciate Dr. Safa joining us tonight. As you can see, he's got an extensive resume, time spent in Dubai, obviously has a very successful practice working down in Florida, and obviously also a part of the PIKOS Institute, a faculty member there. So really appreciate Dr. Safa being on with us tonight. I did clarify that he prefers Dr. Safa, so I don't want anyone to feel like I'm not saying it correctly. So Dr. Safa, I wanted to let you guys introduce yourselves here, and specifically, maybe you could talk a little bit about how you came to know Dr. Kofford and came to start using Smart Denture Conversions.
Yeah, hi. Good afternoon from Florida. Thank you for the introduction. You forgot to mention that Brandon is a board certified prosthodontist. For those of you who don't know, board certified prosthodontists are slightly better than normal prosthodontists. So just kind of maybe Brandon is the exception, but anyways, yeah. Brandon and I met by coincidence. In fact, actually, I've heard of his product, but I've never really met him. And I was in between changing positions. I think this traces back to 2019 probably, and I was interviewing for a position. There was a practice that was looking to acquire me as an associate. And I walked into this practice, and I had no idea that day that I was there for the interview that Brandon was going to be there also, showcasing his product. And of course, this was the early times, and Brandon was him and himself with his company, and he was literally going from office to office trying to show what he can do and what his product can do. And it was just thinking back, such a surreal moment meeting you like that. And we had a very brief conversation, not knowing that years later we would become not only good friends, but we would actually become colleagues in education, and we would be growing old together and having white hair, and gaining a lot of experience, and not realizing that you and I were pretty much doing things the same way without even having to talk about it. So yeah, that's how I met Brandon, and that relationship grew stronger and stronger. And I think it was maybe in 2021 that I invited you over to the office, where you came in and you spent a couple of days with me and the lab techs, and spent a couple of days just treating patients together and doing conversions together and realizing that you and I do the same things, not knowing that we do things very similarly. So, and then after that, once you left, then I saw your company grow and grow and grow, and now you're no longer by yourself in the company. You do have a big team, and your product has proven to be very successful and do the right things for the patient. So yeah, that's a very brief introduction of how we met and how this relationship just sort of matured into becoming more than just a business relationship, but also a friendship.
Yeah, and I have to be honest with you, Safa, that when we first met, I had no idea what a big deal you are.
Mm.
And that just, but I've come to learn that Dr. Safa Tahmasebi is a really big deal. Like, uh, his surgical skills are so impressive. His pro skills are far better than my pro skills. So, it's been really fun for me. And one of the great gifts that I get out of having introduced Smart Denture Conversions is I get to meet amazing people like Dr. Safa Tahmasebi, and I'm just really honored to do this webinar with you tonight. Um,
Yeah.
I do want to ask everybody in the group, Cameron, can you enable this poll?
Yep.
When did you start using Smart Denture Conversions? And this is important for Dr. Safa and I to know because there have been several iterations to the protocol that have come out over the years. Like when I was doing things in 2019, way different from how I do them now, even though I was using the same products. It's just that um, the protocol was a little different. So if you learned from me in 2019 and you haven't like kept up, then you're going to see stuff like, oh, I didn't know that. I didn't know that. And that's because the protocol has continued to improve. Tonight, we're going to show you an actual improvement to not just the protocol, but also the product that I think is a huge enhancement. Dr. Safa might have his opinions, but I think it's a huge improvement. So I hope to get to this soon. Cameron, are people answering?
They are.
Oh,
So we got about 53 people who've, sorry, 53% who've submitted. I want to give people another about 10 seconds, get those votes in. So count it down here in just a little bit. If you don't get your vote in, now's your chance. And give you 5 seconds. 4, 3, 2, 1. Gonna end the poll. I'll share those results for everyone to be able to see.
Hmm.
A lot of you in
great.
2023.
So we have
Yeah.
9 out of the 42 who are just here to heckle me, and I I look forward to seeing what those heckles look like in the chat room. But thanks everybody for being here. We're excited to show this off. So I think if you just in the majority were taught in 2023, so there's probably stuff here that you're going to see that is new in the way of the protocol as well as the product. But let's just review real quick the original product, what we call Smart Denture Conversions 101. So it was all based around this separating action of the head of the screw, which was made out of PEEK, and the threads of the screw, which we call a threaded post, the threads of the screw, which are made out of stainless steel. And so with about 2-3 pounds of force, you could separate the head from the threads, which allowed us to do a closed mouth pickup of the tie base or the temp cylinder using the screw to attach to the multi-unit abutment, which made it so that we could preserve the most functional surface of the prosthesis and end up with a very nice looking provisional restoration after we've snapped it apart and then done our drill out, creating our screw channels after the fact. So these are the 3 main components. We've got the P-cap, the threaded post, and the tie base. And that tie base was picked up into the denture, and then we just created our screw channels through the tie base. The tie base itself kind of acted like a drill guide. The PEEK cap kind of kept you straight. If you had, if you were paying attention, you could just go straight through and it wouldn't damage the tie base. This is one of my friends in Ohio, James Angeloni, the denture man. And when he learned about it, he referred to the old conversion technique as big hole and the Smart Denture Conversion says small hole. Well, that's significant because the big hole that you put into that denture required a lot more work to make it look fun, make it look good. But also you were destroying a lot of the structural integrity of that prosthesis. And so the small hole preserves the structural integrity of that prosthesis. And so fracture rates have decreased significantly in my practice. Dr. Safa, have you observed any improvement in your practice from when you were doing conventional conversions to smart denture conversions?
Oh, for sure. I mean, it was a noticeable change when we went to smart denture, for sure. Particularly around teeth popping off or fracturing individually. No, I am 100%, because again, we were not boring those massive holes into the dentures anymore.
Yeah, and I think one really important protocol element that I've come to appreciate is using monolithic dentures for my conversion prosthesis. Safa, what are you currently using for your conversion prosthesis?
Currently, we're using printed material, the Onyx Tough 2. After design, we print them in-house with the white and the pink sort of cured together, and then we pick them up with normal acrylic.
Perfect. Awesome. All right, so anybody who's been trained by me, they know that I harp on this one point. The pre-coating of your tie base prior to putting it in the mouth is an absolute clinical necessity. I harp on it. There are two reasons for it. One is it makes the separable fastener and the tie base act like one. And second is it makes it for a more predictable pickup. So the pickup material doesn't have to find its way into the undercuts of the tie base. The viscous pickup material doesn't have to find its way into the fine undercuts of the tie base, but it just has to make contact with that pre-coat, and you'll get very predictable pickups. So this was an absolute necessity. Well, Safa is a very trusted advisor to Smart on X. He and I talk a lot, and he was always telling me, Brandon, you have got to make the parts pre-coated. You should not make a product and then expect your customers to have to do this themselves. That's like low class. High class is making it pre-coated already. Well, Safa may have told me this 3 years ago, and we've been working on it for a very, very long time. So that's why I'm so excited that we finally have a solution to those who have been pre-coating by hand themselves to get the benefit of pre-coating without having to do it themselves. And that's what we call Smart Denture Conversions 2.0. So here we have these pre-coated tie bases that are pre-coated with the separable fastener technology is actually incorporated into the pre-coat material. And you see here that the material itself is polycarbonate. So it's a polycarbonate shell. And then that's why you don't need to pre-coat it. The polycarbonate is the pre-coat. And you see that there's a stem that helps aid in delivery of the tie base to the multi-unit abutment. Here we have the threaded post is friction fit into a polycarbonate screw head that is integral with the polycarbonate shell that is on the tie base. So there is no more peak cap. What's holding that separable fastener threaded post is polycarbonate. Another thing that Safa always harps on, and Safa, I'm going to actually let you speak to this, is the importance of that polished collar of your tie base, which I hadn't been paying attention to. I kind of just designed the first tie base, just, whatever. But Safa really harps on the importance of the polished collar of the tie base. So Safa, can you explain to everybody listening why that polished collar is so important to you?
Yeah, and I guess maybe how can I put this? From a surgical standpoint, we wanted to find a way where we could perhaps maybe standardize the way our multi-units were placed um, in relationship to the hard architecture of the bone. In other words, when we were done with our bone reduction and the final definition and perhaps maybe the burnishing of our hard tissue, which was sort of the hard architecture of the bone, we wanted to place some multi-units in a fashion where the multi-units were all at the same dimension vertically. And then once we had done that, then we wanted to find a way where we could tell the lab technicians to understand the dimensions between the intaglio of the prosthesis and that hard tissue. So that once that dimension was defined, then a zone of biological width or biological zone will be sort of defined by the tissue, by the prosthesis, and the tissues will sort of be molded or trained by that prosthesis. So we needed to find a way where we needed to know the exact dimensions from the bone, from the bottom of the bone to the top of the multi-unit to the prosthesis. And that polish sort of tie base with the 1.0 originally was a 1.66 collar. I remember sitting there on a drawing board with my technicians, and one of them asked, well, what's this length of this polished collar? I said, I don't know, let's call Brandon. I remember picking up the phone and calling you and say, what is the dimension? And you're like, I don't know. And I remember you saying, well, let me talk to my engineers. And then you called your engineers, and then you returned the phone call the next day. You said it's 1.66, and you said, perfect. So now we have a number that we can go by. And so that number 1.66 really kind of got embedded into our minds, and we started using these dimensions to train our maxillofacial surgeons, because I was training different maxillofacial surgeons at the time to do surgery for me, and so we needed some set known dimensions, and that's what that polish collar did for us. In fact, actually, it was Smart Denture Conversion that allowed us to standardize those dimensions and be able to create intaglios that were reproducible and were repeatable. And the reason why that happened is because we knew these dimensions, and we experimented with the height of the multi-unit in relationship to the bone, keeping these dimensions uniform. And so for me, it served two purposes. Number one, it served to reproduce the surgery the same way every time. And then the second thing, it allowed us to know exactly what dimension of biological zone are we going to require underneath our prosthesis, so that tissue can be trained so that the prosthesis will have the right intaglio by the time the healing comes around.
Yeah, so I mean, for anybody who's not familiar with the protocol, you're not doing an impression of the soft tissue. The soft tissue at the time of surgery is essentially irrelevant to how you're designing your
Right,
intaglio contours. And what
right.
you came across, and I love what you teach, is the importance of the conical connection, the deep conical connection implant. Your multi-unit abutment has to have a very sleek emergence off of that abutment or out of that implant, so that your bone profiling is minimal, if at all.
Exactly, exactly.
And then you're getting that multi-unit abutment to sit essentially just above the level of your bone.
Right.
Maybe half a millimeter. Do you know that?
Right. Well, I mean, different implant systems have different dimensions, the different collar
Sure,
heights. Depends on the implant system that you use. The
that's
implant
true.
system that you're referring to, yes, does have a 0.5 millimeter collar on the angle, and on the straight, it has a 0.3 millimeter collar.
Okay. So, but I guess the important thing there is to know the dimensions of your components, and that will help you optimize the surgical and prosthetic outcomes, especially as it relates to the intaglio contours of your prosthetics,
And
which I would
standardize
argue,
and do it the
and
same every
standardize.
time. We're standardizing,
Yeah,
yeah.
yeah, it's for predictable outcomes. All right, perfect. Thank you so much.
Yeah.
So, and so this polycarbonate material is actually pretty tough. And so it doesn't just snap away like an acrylic would. You have to bend it back and forth until it breaks. But it is intended to just hold on to, screw it down, and then bend it back and forth a couple times, and it breaks right off. Now, we do have also with this pre-coated version, we had the ability to get rid of the threaded post altogether. And so we have the threaded post version and the non-threaded post version. So we'll call it no post, right? So here in the threaded post version, you see the dimensions that are important to Dr. Safa to really know the dimensions of his products. So this polished collar is parallel walls rather than the original tie base that we designed had a tapered wall to it. So the soft tissue would grow over it like this and make it difficult to reseat the prosthesis. So this parallel walled collar improves that contour. It's 1.8 millimeters tall, and that's for functional purposes, functional and strength reasons. And then the shell adds 3.5 millimeters to that 1.8. So the overall height of this tie base is standardized. It is 1.8 plus 3.5, which is going to give us 5.3. Am I right? Did I do my math right? So
Yeah.
it's 5.3 millimeters tall above your multi-unit abutment. Now, the tie base itself is engaged, 2.8 millimeters are engaged with the polycarbonate shell.
Mm-hmm.
The other thing that I want to point out here is you can see the polycarbonate portion that's holding onto the threaded post. It's not resting on anything inside the tie base. So when it comes to our drill out and removal of that component, it's a lot easier because it's not really sandwiched inside the tie base. Now, the no threaded post version is actually pretty cool because it doesn't have to even rest over the screw seat of that tie base. So the drill out is really, really easy to get that tie base free and clear of any debris inside the screw seat of the tie base. All right. Now, as far as the connection of the tie base with the polycarbonate pre-coat shell, we've tested the pull-out strength required to dislodge that tie base from that polycarbonate when you've embedded it in the prosthesis. And it just, I mean, having that polished collar exposed beyond the acrylic, like Dr. Safa's protocol requires, the pull-out force is 155 pounds on average. That's not going to pull out. It's not going to dislodge. The pull-out force of the separable fastener threaded post is on average 2.6 pounds. So not much of a difference from the separable fastener from Smart Denture Conversions 1.0. The threaded post version offers the advantage of still being able to use the press-on caps, which are a very efficient way to just move on to, because I do an open flap pickup, so you just snap those on and then you get to suturing. Dr. Safa does a closed flap pickup. And so, Dr. Safa, do you use the press-on caps or do you use healing abutments?
I use the press-on caps.
Yeah, so it's just very efficient to press that in place and move on.
Yeah.
Whereas with the non-threaded post version, you would have to screw in healing abutments. All right. Here's another poll question. What is your go-to pickup material? So Cameron, if you can enable this poll, everybody in the webinar, if you could answer PMMA or chairside by Zest, easy pickup by Sterngold, Stellar, Quick Up, or other. And if it's other, excuse me for my cough, if it's other, please list it in the comments or in the chat room.
Yeah, I was gonna say I
I
don't see peanut butter on here.
Or bazooka bubblegum.
Okay, we'll give it another 15 seconds here. Got one comment in the chat.
What did they list?
Unifast trad.
Okay, PMMA. Unifast trad is PMMA. Yep.
Yeah. All right. We will close this in 5, 4, 3, 2, and 1. Let me share those results.
Awesome. Okay. I'm really excited to see that so many people are using PMMA for your pickup. I am going to try to convince you that PMMA is the best material for a denture conversion. Dr. Safa, do you have any qualms with that statement?
Oh, for sure. No, no doubt. I mean, we'll talk a little bit more about that, but no, absolutely.
Okay. All right, let's close this out.
Just a quick comment, Brandon, that perhaps maybe we should have alluded this about this pre-coded story. I remember when we first met, there was a colleague of ours who was using this in Nashville. Take this, and then I remember talking to him. This goes back about 7 years ago. So tell me, what do you think about smart denture caps? And he goes, "Oh, I used to use it all the time, but I hate it now. What happened? Oh, sometimes you don't have acrylic adhere to tie bases, and you don't pick them up. And I think you know who I'm referring to." Um, and this individual failed to understand the protocol, and the protocol was that you need to have acrylic around those tie bases, um, placed over the tie bases prior to surgery. Now, for people that are typically prepared, that's a very easy thing to do. Nowadays, what we do is we just acquire the tie bases, give them to our technician, and while in the morning the technicians are waiting for the surgery to arrive, they were just sitting in there and they're adding. And you could have your assistants do them, you could have your wife do them, you could have anybody in the office do them, and you could do piles of them, and you could have these little center blocks that you could create from putty, and you could just place them in there, and so if you're prepared, that's great. But I remember I would go to offices, and I would say, "What system do you use?" "Oh, we do smart denture conversion." "Great. I'll do the surgery and you do the smart denture conversion pickup." "Great." And then I arrived to the office and they were not coded. "Why didn't you code them?" "Oh, we just bought them and didn't have time to do them." So I think that the fact that you have decided to go to the prefabricated coating, in the sense that they come pre-coated from your company, or at least from the purchase, the way you buy them, is going to, number one, sort of eradicate the need for having to spend some time prior into doing that. And also, it will eliminate not them being picked up, which I think, in my hands today, example, I did a double arm for in the maxilla, um, and the acrylic. I have a new assistant that I just hired, and she makes the acrylic too doughy, so the acrylic didn't pick up the back two. For me, it's not a problem. I just pick them back the other two. In fact, actually, when that happens, the fit is so much better, and I think you understand why. So
Yeah,
it's not a problem for me because, of course, I have a lot of experience. I've probably done close to a few thousand of these, and so it's not an issue. But I think for the case, for the sake of standardizing the process and making it easier and bulletproof, I think what you've decided to do here is going to eradicate a lot of potential problems that could happen chairside, because it is not the product that's the problem; it's the person using the product the wrong way that's the problem. So I think
that's
that
right.
this kid. this can eradicate that issue.
Yeah, and it goes back to what you were saying about having a standard, like a standard protocol for how you approach surgery and how you place your implants and how you select your multi-unit abutments, and you standardize everything so that you get predictable results. And
Yeah.
so rather than, oh, this assistant pre-coats this way and this assistant pre-coats that way, and you're getting non-standard results, this just standardizes it.
Yeah, and I've heard also, like, I've heard one person say, well, you know, because we would sort of screw them on by hand. I've heard people say, oh, they're too little and it's slippery and it's hard to. Well, now you have the knob, which makes it easier for you to turn it around. So again, you know, I think what you're trying to do, and I understand what you're trying to do here, you're trying to make this product easy to use and user friendly. And that's
Yeah.
great, because I think most things should be like that, because we get busy at work, we get tired, and the easier for things are, you know, why does everybody love Tesla? Because it essentially drives itself to work, and you don't have to worry about driving
Right.
in the morning or you commute from home. This is also the same thing. I mean, you're trying to make this very easy and self, you know, efficient. And so I
Yeah.
commend you for listening to your consumers and doing what needs to get done.
Yeah, and unfortunately, when working with the FDA, it's not always a quick fix. You know,
Right, right.
we do take feedback from our clinician customers very seriously. I'm a clinician. Like everybody
You're
asks,
right.
like, oh, do you still work in the clinic? Yeah, Monday through Thursday, I'm working in my practice.
Yeah, yeah,
So
yeah,
I'm
yeah.
I'm a
You have
clinician. I
to. You
totally
have
get it.
to. Yeah,
And I
yeah.
love
You
getting
have to.
feedback from people, like especially Safa and all of his great feedback that he's given us over the years. So we
Yeah, yeah.
listen. It just isn't always a quick process to get through the FDA. And speaking of the FDA, when we expanded our operations into Canada and as we're preparing to go into Australia, we needed to be able to make the dams available to those customers as well. And so everybody who's ever worked with me, you know, Dammit Dental, he's a great friend of mine. I love Dammit Dental. But we needed to offer dams that were could be available to our customers overseas. And you know, we had to follow some FDA processes to make these dams available. So Dammit Dental has the template, and then you have the silicone dam, and you use the template to index the multi-unit abutments, and then you overlay that over the dam and you punch through it. Awesome. Well, my engineers, they said, well, what if we could eliminate the need for two dams? So what they came up with is um, a silicone dam that has a vinyl adhesive or an adhered vinyl layer that allows us to index the multi-unit abutments into the vinyl. You just punch through that, and then you tear the vinyl away. The design of this silicone dam actually came from our work with the rapid arches project that I did with my lab technician during COVID in 2020. And so we took the small rapid arch intaglio and the large rapid arch intaglio. We overlaid those to get the dimension of an arch that would incorporate small all the way up to large. And then we just designed the silicone dam to accommodate those arch forms. So this should be a more universal arch form and easy to establish in the against the multi-unit abutment. So here you see indexing to the multi-unit abutment, and the vinyl leaves that impression. So then you just punch through it and then peel the vinyl away. Now, here's the other improvement that I have absolutely loved. This rapid set pickup acrylic. It takes like 2 to 3 minutes to set intraorally. It's quick, it's really reliable, and it is super easy. Everybody always says, oh, I don't want to use PMMA because you have to mix it yourself, and then you have to backfill it into a monojic syringe, and it's messy, blah, blah, blah. Well, it doesn't have to be. So here we use pre-dosed acrylic. So pre-dosed powder, pre-dosed liquid. You just dump the powder into the liquid, you mix it, and then you just draw it up into the syringe. Let's see. Oh, it can't play the media. So you just draw it up into the monojic syringe through the tip. You don't have to backfill it. It's not messy at all. And so these are the pre-dosed vials that we make available. So it's a 15 cc powder and a 7.5 cc liquid. And you can buy these in 2 arch packs, 5 arch packs, or if you're Dr. Safa's level, you can go to a 24 arch pack. Or you can just buy these large bottles and dose it out yourself. But the pre-dosed vials are actually pre-measured, precisely measured, so that you get consistent results every time. It doesn't matter which assistant is assisting you. It's the exact same result every time. Now, this is why the polycarbonate shell and the PMMA pickup material is important. PMMA is the only material that will bond with the polycarbonate. So the chairside material from Zest, Stellar, Easy Pickup, Voco, those aren't going to bond with this polycarbonate shell. So you're better off with the Smart Denture Conversions 1.0 version. But if you're open to trying PMMA, you're going to love the pre-coated parts. You're going to love the pre-dosed acrylic, and you're going to love how easily it draws into a monojic syringe. It's really worth giving a try. That being said, I'm going to turn the time over to Dr. Safa to walk us through your clinical protocol for Smart Denture Conversions.
Yeah, just a little note about this pre-mixing coating. You know, I go through a lot of assistance. Of course, we have a high turnover rate sometimes in your teams, and I think everybody agrees that every time you bring a new member into your team, you have to train them, and so I think the fact that you've again, you've decided, you try see what you're doing here. You're trying to again make this bulletproof, and make it easy for assistants to not have to sit there in the middle of the day with the graduated cylinder trying to measure how many millimeters of liquid, So yeah, so I get what you're trying to do here, and I think it's 100% beneficial what you're doing, and just makes it easy. You just pour them together, mix them, and then because it's pre-measured, it just makes it easy. Again, I don't know where you got that idea from, but that's pretty smart. Before we move on to this
His
video,
name's Safa.
yeah, you're right. I think that before we move to this video, I think there's a mediocre prosthodontist by the name of Nick Egbert that has a question. I don't know if you want to answer the question. Yeah, very mediocre prosthodontist,
Yeah.
Nick Egbert. Yeah, you
Yeah,
may want to answer his question.
I won't dare call him mediocre, but in the chat, he asks, are the no post press fit, the no post tie bases, how much does that affect the angle of divergence?
So it doesn't really affect the angle of divergence. It's going to be the exact same that you have with Smart Denture Conversions with the threaded post. So that's the nice thing about the polycarbonate material as opposed to PEEK. So I mean, there should be no. I don't know if I'm going to get in trouble for saying this, but we're in a lawsuit against a very large implant company, perhaps one of the largest in the world, for stealing our intellectual property. We have a patent on this concept of a threaded screw that pulls out of the multi-unit abutment. And we're in the middle of this litigation, and we'll see where things go. But they chose to use a very stiff material, and that requires a greater pull-out force. This polycarbonate material with different diverging angles, and by the way, Nick Egbert for anybody in the room or the webinar listening, he is one of the most fantastic prosthodontists I've ever met. Like,
He is.
he's the big deal, and everybody should check out his training platform, implantability.com. It's awesome if you want to learn from a true master. I, as the inventor of Smart Denture Conversions, was in his practice in April, and he was teaching me. He was teaching me how to remove the peak cap out of the tie base. Now, Safa, you might have something to say about that too, right?
Yeah.
So Safa and I, we've taught at several courses, like a dozen courses. And he kept telling me, Brandon, I don't know why you teach people how to do that 5x5 bull crap. It's so difficult. It's so confusing. There's an easier way. And I was like, Safa, whatever. And he was trying to teach me what Nick Egbert taught me just this past April. Anyway, I highly recommend everybody check out implantability.com. It's amazing. So that's a great question, but the angle of divergence is no different than from Smart Denture Conversions. You'll have the same ability to pull it out. All right, Safa,
Yeah, so
are you ready?
get into this to this video. And so yeah, you know, Brandon, you sent me these parts and you wanted me to just kind of try them out. And this is the silicone dam that you talked about that's bilayered. It's got a sticky part on the bottom. So you just, the important thing here to realize, make sure that you hold one of the implants and never move it around, because you want to make sure that you get that indentation uniformly across the arch, across the 4 implants. And then once that's done, then now here you can go ahead and put your pre-coated tie bases on. And what I didn't learn here, what I didn't know here, I wish I talked to Brandon before doing this, is that once you screw this on by just going clockwise, in order to snap this off, you should try to see if you could hold the bottom pre-coated polycarbonate before snapping the top off. So that's very important to do that, because in the beginning I didn't know that, and sometimes that pre-coated kind of wiggled loose a little bit. So that's a very important thing to notice. And also, as you could see what Brandon was talking about earlier, you could see the implants here in relationship to the hard tissue architecture, pretty much the bone. So, you know, you could see the collar of the multi-units are pretty much within the same height. And so that polished collar of 1.8 millimeters allows us to be able to communicate with our laboratory technicians in giving them a uniform sort of dimension, so that they can create intaglios that are reproducible in all the arches, so that we can get the same results. Brandon, you wanted to say something about
Well, yeah, how far subcrestal would you say that your implants are placed in this particular case with the implant system that you were using?
Again, I don't remember. This was a surgery that I did last week to create this video, but it also really depends on the density of the bone. So if the bone is really dense, then it's very difficult to put the implant too subcrestal. It becomes an issue. You could get stuck. And then if you get stuck now, you could break components and whatnot. And there are a lot of people that say you shouldn't insert implants with too much of a heavy torque. But if I remember correctly, I don't use anything short of 2.5 millimeters. And you could see that multi-unit is about 0.3 millimeters. So I would say that implant is anything between 2.2 millimeters and deep. If it's at 3.5 millimeters, then that implant is probably 3 millimeters deep. But I'm pretty sure that those are about 2.5 millimeter multi-units sitting above the bone by 0.3 to 0.5. So subtract 2.5. So those implants are about 2 millimeters subcrestal.
Okay, cool. And then I also wanted to just point out, right now you're placing the components with the flap open.
Yes, exactly. Very important. So once you place your multi-units, you want to put these on, and then you start suturing around this. Very important to do that. Actually, I'm glad you mentioned this. You know, along this smart denture conversion journey, there are steps that we will talk about as we go along that are cardinal. I call these non-negotiable steps. Pre-coating your tie bases, whether you buy them or you're pre-coating yourself, is a non-negotiable step. Putting these on before you close the flap is a non-negotiable step. I speak to many people that are frustrated with Smart Denture, and I say, why didn't you like it? I said, well, we put the healing caps on, we closed, and then the prosthodontist had a hard time putting the tie bases on. And then I say, well, why don't you treat the tie bases as the healing caps? Oh, you could do that? Well, of course you could do that, because look at them. They look like healing caps. And why not doing that? Because when the flap is open, you can make sure that this thing is fully seated. Because when you close the flap, put your healing caps, close the flap, and then come back to remove the healing caps to put these things on, now you can't really see whether this thing is seated. So again, I'm glad you asked that question. That's not negotiable. After the implants are placed, multi-units are torqued into place, then these have to be placed prior to flap closure. And so now, once everything is placed, then this is where we suture. Again, if you want to pause it right here, I didn't really show an example of it here, but intraosseous sutures is a non-negotiable step in the Smart Denture journey. You have to put those intraosseous sutures. And for those of you who are familiar with it, that's great. For those of you who are not familiar with the intraosseous, is you create a very small bevel between either the lingual or the buccal crest, and you create a 45-degree bevel at the edge of the buccal or the lingual crest, and then you bite the facial tissue. You get a bite through the bone, through the lingual tissue, and you close that. Why is that a cardinal step? Well, if you don't do that and the tissue is just flapping around, then that tissue can sort of tent over the healing caps, or sorry, the tie bases, and then you could lose the tie bases. And there's some studies that are coming out, and maybe someone can put the study here and a comment on the comment section, that that the people are noticing that when intraosseous sutures are placed, the tissue results are much better, that the biological zone is established much better, and the body has a easier time to heal. And it makes sense, because it takes 45 days for that blood clot to transform into periosseum, and for that periosseum to become connective tissue, and then epithelium. If you tack that soft tissue to the bone, what you're doing is that you're reducing mobility of the soft tissue, and you're making that blood clot stabilize, and essentially you're improving the healing capabilities of these patients. And so ever since we started doing Smart Denture Conversion, and we started doing intraosseous sutures, we started seeing much better healing capabilities of our patients, and we started seeing a much better result with the periodontium, connective tissue, and the epithelium, and the attachments around the head of the implants and the multi-units. And so that's a non-negotiable step, and it's cardinal into this Smart Denture Conversion sort of journey. And then so once that's done, then these are it's fully sutured, fully closed, and then we take that indented silicone that we had punched through. We try to line up that punch, and then we remove that sticky part, and then now we go ahead and we place that over our pre-coated tie bases. And this should be very easy to do if you've done the right bone reduction, if you've done the right tissue resection, if you've done the right implant placement. This should be very easy to do. And then once that's done, then you take your little the rings, those donut rings, and you use those to stabilize the silicone, so that when the patient moves their tongue around, or perhaps maybe if there's any redundancy in the tissue or hyperplasticity of the tissue, the silicone dam doesn't go over the tie bases, and it stays stabilized as you inject your acrylic. So that's one
So
that you did. Yeah, go ahead.
So I just want to pause here and ask, like, there's not a whole lot of tie base sticking above that donut there, Dr. Safa. Like, aren't you worried about not picking up?
I remember you telling me this because I remember asking you that question because in the beginning we didn't know how much of that type base should ought to be exposed. I remember calling you 5 years ago and asking you, Brandon, have you ever had? And you remember, I remember you telling me, Safa, all you need is 2 millimeters to be able to do the pickup. I remember you telling me that. But I think if you continue the video, you would see that all you need to take is can take your college forceps and you can press them down. Now you can see more of them exposed. So all you got to do is just kind of um, so then we go ahead and take our pre-measured powder and liquid, we mix it, and we inject that, and then we hold that. You could use your bite here, or you could hand articulate it and then have the patient move into centric. The important key here is that you want to make sure that the retractor is not pulled away before the excess material is removed. Sorry for this video, it doesn't show that part, but and then that's it. And then you dislodge, and then you create this beautiful provisionals that can be fabricated within 20 minutes and inserted into the patient's mouth. And you could see the screw access hole positions are perfect. And because again, our bone reduction was done correctly, and this prosthesis is mono-layered, we don't even cut the cantilevers. I mean, you could say that this is not a cantilever. Maybe on the left side it is a cantilever, but we don't even cut them. And I can't remember the last time we had one of these cantilevers fractured because it's strong, because it's a mono-layered material, and it has the right horizontal and vertical dimension at the ponic space in the back part area.
Well, I mean, as always, Dr. Safa, you do such beautiful work. Now, my big thing has always been, if you can make, and Dr. Guillory is on the webinar here. So she was my mentor in residency, and in my program director and all of my mentors in residency would always harp on, if your provisional restoration looks like what you want the final restoration to look like, then life is easy. And so what we have here is a beautiful provisional, which is very similar to what I expect the final restoration to look like. And Safa, when you do your index, I'm sorry, when you pick up the mandibular arch, you're indexing to the maxillary arch.
Yes.
And rotating the patient into the intaglio. So how much occlusal adjustment are you doing on these cases?
Well, I mean, I don't want to do any occlusal adjustments, right? I mean, you got to understand that these patients have had a hard day. They've had a tough day. You've had a tough day. Everybody wants to go home, and everybody wants to have the least amount of chair time. And so the least we do on patients, the better experience that these patients have. And so occlusal adjustment is something that we don't want to do. And so because the maxillary is already set and secured, and we are rotating the mandible into centric, the patient is the articulator. The patient is the occlusion. The joint is captured in its most orthopedically stable position, according to Peter Dawson. So rarely do we have any adjustments that need to be done at surgery time. There's a couple of questions I wanted to on the chat. Somebody asked, what type of suture material are you using for your intraosseous suture? You know, this sort of came to us by evolution. Of course, the majority of people use chromic gut 3.0, and there's nothing wrong with that. But my experience has been that glycolon, which is a monofilament 4.0, is the best one. It's my favorite suture, and I think you could see it in the photo on the top left. It's a very easy suture to use. It doesn't get stuck to the acrylic, and it just doesn't unravel open. And sometimes when these patients come back, it's resorbable, but you could actually see it on patients 2 or 3 weeks post-op, which I like. I like something to be there holding the tissues together long term. So glycolon 4.0 is my favorite suture material to date. What type of burr do you use to do that bone penetration for the sort of the suture to do the intraosseous suture. Any burr works. I use a Fisher burr on a high-speed handpiece. And any Fisher burr, you could even use a diamond. It doesn't matter what bird it is. You need to make sure that it's a bird that can go on a high-speed electric handpiece with a water port from your sterile water that comes from your implant unit. But any bird that you use is fine as long as it's a thin burr, it doesn't overheat, that use a lot of irrigation, and the thinner the better, because obviously you don't want to create big holes into the jawline, the jawbone. And then yeah, I think and then Bruce, so kind of him, um, commented there. So yeah, Brandon, did you have another question about this, or did you want to carry on to the next?
No. We'll carry on. But this beautiful work. There's a reason why I'm not presenting my surgeries.
Oh, sorry, I was actually giving a lecture.
When you have
Yeah,
friends
you
as
put
talented as you, there's no reason for
no,
me
I
to
would.
show my butchery online.
I wouldn't go that far. In fact, actually, I was giving a lecture on zygomatic implants in Barcelona. So, and you kind of caught me in the last moment, like, Safa, I'm going to send you the stuff with the webinar, and I was running out of time. So I apologize if this is not a picture perfect position, or maybe there's, but this was done literally 6-7 hours before my flight, and then I had to edit it on the plane and then send you the videos and the photos. So my apologies if it's not picture perfect.
No worries. All right, so one last poll, everybody, if you could just answer this question. How do you design your intaglio contours? This is a really big deal to me. Cameron, if you could open that up. So again, these patients, they deserve our best, right? And so there's a lot of debate over how to design the intaglio contours of a full arch fixed restoration. And so I just want to hear from you guys. Do you believe in food storage? Nothing stores better than a dish, like concave contours. Do you like your intaglio contours high above the gingiva so that they're not even touching the gingiva? Do you like your intaglio contours to be convex or flat, to be cleansable? Do you like your intaglio contours flat with the MUAs? So Safa is talking about his tie bases project about 1.5 millimeter, 1.8 millimeters above the plane of the intaglio. Do you like to have yours flush with the, do you want your tie bases flush with the intaglio? Or do you, do you have it like Safa where it's 1.5 millimeters proud above the intaglio? All right, how are we doing, Cameron?
Doing pretty good. I want to make a quick programming note. I know we're already at 8 o'clock, and so we appreciate those of you who've stuck with us. And we know we have some questions as well that we do want to get to. So please hang around. We will get to those questions. We do also have more announcements to make about SDC 2.0. So there's still a good chunk of material for us to get to. If you're able to hang around, great. If you're not able to hang around, please put your questions in the Q&A and we will get to them. But I'm going to end the chat now, or sorry, end the poll. And I'm going to count down. Please get in those submissions. 5, 4, 3, 2, and 1. Let me share those results.
Oh, wonderful. I love it. Good. I'm glad nobody selected concave contours. It drives me nuts. I see so many of them come through my practice. Not me doing them, but patients moving from other places and they've just got these horrendous concave contours, and it just is so sad to me.
Yeah, I couldn't
All
agree
right.
with you more. And in fact, actually, Brandon, we always make the joke that we don't want to see your Thanksgiving dinner for Christmas, right?
That's right.
And we always make that joke, but it's true. I mean, you know, credit to our predecessors or to our colleagues from the past is that they didn't really know better, right? I think credit to them is that this procedure, the full arch implant reconstruction, sort of with the FP3 prosthetics, it evolved with time. Paying attention to the intaglio was something that we were not doing in the past. We just wanted to get implants in there, and we were learning immediate loading. How many implants do we place? Where do we place the implants? We were trying to understand primary stability, implant design, prosthetic space. There was just so much in the past 25 years, 30 years that we were learning, that paying attention to the intaglio was not really on anyone's radar. And so when we
Right.
see some of those older cases come through the door where you remove the prosthesis and you find a dead animal underneath there, I mean, to me, at the beginning, I used to get so frustrated, and I used to get so angry. How can someone do that to someone? But then with time, I realized that we didn't know better. And I think for me, my journey with smart denture conversion is really what sort of pushed me into trying to understand how we can have reproducible results with the intaglio and create situations where now we have really, and I lectured about this in Barcelona, in Spain, and many people came to me and asked me a lot of questions about this idea that now perhaps maybe we could create intaglios that are so self-cleansable that we don't even have to remove these prosthetics. Imagine not having to remove your prosthesis ever. Imagine not only for you reducing chair time, reducing the wear and tear on the prosthetics and the screws, but imagine the patient. Do you think patients like having their prosthetics removed? They don't like it. A lot of them get really angry when you say, "Oh, we're going to take your prosthesis off at the hygiene appointment." A lot of them are embarrassed. A lot of them are in there with their spouses or their loved ones, and their loved ones don't even know that they have teeth that are made out of prosthetics or implants. And so we try everything we can to create prosthetics and intaglios that are so self-cleansable and self-sustaining that they don't never have to be removed, and food and bacteria and biofilm doesn't even have an opportunity to enter, and let alone to stay there and accumulate and turn into calculus. And so really thank you for bringing that up. It's really the most
Yeah.
important things and probably the most overlooked part of this follow-up implant reconstruction sort of journey that we're seeing happen around us.
Yeah, and I mean, a 1 hour webinar introducing the pre-coded parts is just not enough time
Yeah,
to give it justice, right? But
right.
I will go back to the key is um, uh, establishing those contours in the provisional restoration. And so, like you, I don't cut my cantilevers because I want my intaglio contours to be exactly in the provisional how I want them in the final, so I can train the tissue. And so, in
Precisely.
doing that, we've created this restoration that's really nice, right? And everybody always tells me, "Oh, well, I like doing the digital workflow because I like having a digital record. If anything breaks, then I can just reprint another one." And I'm like, okay, fine. Don't Smart Denture Conversions is not antithetical to a digital workflow, but there are efficiencies that Smart Denture Conversions brings to the digital workflow. And I just want to highlight this one. This is a prosthesis scan body. So what people call a reverse scan body, I call it a prosthesis scan body. You just throw it on the prosthesis after you've done your conversion, screw these on, and then scan your prosthesis in. And now you have a digital record, and it goes into your exocad design software. And then you just real quickly go through it, and now you can create this digital record of what you established at surgery. And it took all of like 2 minutes to digitize it. In this particular version that I'm showing you, I'm making a tie base type prosthesis. And so with tie bases, we also have the separable fastener technology that's used to cement the tie base into the prosthesis. So you can see here what we call a cementation aid holding a tie base to our protective plug. And then you can see that cross section, how those parts relate. It looks exactly like a separable fastener on a multi-unit abutment holding the tie base down. And then this video is sped up 4 times, but you just inject cement down into the well, and then you push those down, clean off the excess cement, and then you pull the separable fastener, and then the protective plugs just drop out, and then you go to a physical model, screw it down, let it set up, and now you have a very easy way to cement tie bases into a digitally produced prosthesis. But people will say, oh, well, how did you get that physical model? You made the provisional restoration. You can just throw some light body impression material onto the Intaglio. I'm sorry, screw on some lab analogs, inject some light body PVS impression material, and then mix up some fast setting stone. And now you have a physical model to which you can either do repairs later down the road if you should have a catastrophic complication, prosthetic complication, or if you're going to have a prosthesis produced digitally, then you can cement the tie bases onto that physical model. And these STLs are available now. All you have to do is ask us for them. So you can email out to, I think, info@smartonx.com. That will respond with whatever STLs you want. And that's for exocad. So now the question is, what does this do to the availability of Smart Denture Conversions 1.0? It's not going away. Like I said, the pre-coded parts only work if you're going to do a PMMA pickup. So if you're committed to your chairside, or if you're committed to Stellar, whatever, then you're better off with SDC 1.0, the tie base, and pre-coding it with whatever material you're picking up with. So we will always provide Smart Denture Conversions 1.0. But now we have Smart Denture Conversions 2.0, which I think is better because it standardizes that pre-coat and it makes it easier. We're not even going to raise the price. It's just another option for you, which I think is a better option. And it's already available on smartonx.com. So you can subscribe to our newsletter or social media for these updates as they come along. And we'd really like to invite people like Dr. Safa and Dr. Nick Egbert to lead us as the Smart On experts. Do we have any other questions that need to be addressed, Cameron? I'm kind of paying attention to the time, trying to get through this as quick as possible.
No, I appreciate that.
Yeah, I mean, yeah, a couple of the questions on the chat group will pertain to your next slide. So if you could go to the next slide. Again, this is a webinar regarding sort of some of the improvements in the smart denture conversion sort of technique. And most of the questions I see here regarding suture lines and position of the implants and abutments and multi-units and height, like Brandon said, 1 hour webinar is not enough to go over that. This is a 3-day course, or maybe 3.5-day, 4-day course that we do. And so actually a couple of years ago, Dr. Mike PIKOS, who, as many of you know, is probably one of the biggest educators when it comes to surgery. And Mike PIKOS, to me, is the Peter Dawson or the John Coyce of surgery, right? So this guy has been around for a long time. He reached out to me. He said, Safa, we want to teach full arch implant reconstruction in our facility. How do you think we should do it? And of course, many of you understand that over the past 5 to 6 years, there's been a revolution, perhaps maybe, of digital dentistry coming into full arch implant reconstruction, and rightfully so. And I think that digital is amazing, and I think that we should be dwelling in the digital, and it's really interesting and exciting to be seeing all the sort of the inventions that are happening in digital. But when we sat around the round table, Mike PIKOS and I, we realized, how do you teach digital outside of exocad and outside of a software? How do you basically teach all the ins and outs of what we just talked about without having a physical model in your hand and doing its conversion chairside and understanding how things need to be done in an analog way so that you could dwell into the digital pathway at some point in your career. And so I told Mike, I say, let me take one of my patients that I've done, and then let's take the DICOM files, turn them into STL files. We send those to Spain. Models were created. So an actual patient was created. We articulated these models together. So this is from an actual patient. And then we brought the digital files of the x-rays. And then Mike PIKOS showed us how to place the implants. And then we placed the implants into these models. And then we did conversions on these models. And Brandon came along and became part of the faculty in this course. And then Brandon started showing us how to do the smart denture conversion chairside. And we had maxillofacial surgeons, oral maxillofacial surgeons come to this course. And many of them came up to us and said, you making us do the conversion, chairside with smart denture conversion, and then you making us trim the prosthesis made us understand this procedure so much better, because now we did it in a hybrid workflow rather than this fully digital workflow. I'm not against fully digital workflow, and I think it's great, and I love seeing what's happening. However, I am a bit concerned about people that are getting into this procedure, finishing off their surgery, taking their gloves off, and giving this over to a technician and saying, okay, I'm going to go play golf, or I'm going to go home. You guys go ahead and deal with this. The problem with that is if when something goes wrong, when you have not designed this case for the buccal corridor, vertical dimension of occlusion, midline, incisal tooth display, arch form, lip support, when you have not understood the position of the implant, when you haven't understood recording the bite eccentric, when you have not understood all of the prosthodontic and surgical principles that we were taught in school, and you're punting that responsibility to a technician to do that, then what happens when something goes wrong? Who's going to troubleshoot problems? Are you going to depend on a technician? The patient is going to be holding you liable and not the technician. And so that's why with the smart denture conversion technique that we teach at the PIKOS Institute, we teach it because we want people to learn this hybrid workflow so that they could learn how to do it using their hands, how to mix acrylic, how to pick up the prosthetics, how to use the palette as an index. All of these things teach you to become a better full arch reconstruction surgeon and a restorative dentist. And so this course here that's happening in August is a very good course that I recommend anybody to attend, whether you're skilled or you've done a few hundred arches and you're trying to take your sort of skill level to the next step. This course is for you. And Brandon is on there with me. Dr. Basma, who's a periodontist from University of Alabama, is on that. And then Mike PIKOS himself. And then there's Dr. Phil Hedger, who is a prosthodontist who works closely with Mike, who's a completely digital dentist. So there's lectures about fully digital workflow. And then Brandon and I do the hybrid workflow, which is a combination of analog and digital. And so you'll get to see both pathways. And then there's a live surgery at the end with Mike PIKOS himself. And then what I love about that day is that after the surgery is done, Brandon goes in with Mike and does a chairside pickup and then does the conversion in under 20 minutes. And it's just really fun to watch because he has a stopwatch and he turns around and says, look, I'm going to finish this conversion in 20 minutes. And that's really the idea of the smart denture. Why smart denture conversion really works well for me is because of the speed, right? Our patients, we run deep sedation in our clinic here. Our patients are fully sedated. And when sedation is done, I want my patients out of my office. I don't want that fentanyl and that ketamine to wear off, for the benzos to wear off, and for these patients to wake up and require more local anesthetic, and for them to become sort of combatant and tired. And I want them to have a great experience. After surgery, my patients are at the door within an hour for double full mouth implant reconstruction, and they're at the door for a single arch within 30 minutes. That to me is very important, and that's what smart denture does. Do I do digital? 100%. I'm an educator. I teach. And so it's my responsibility to do digital dentistry. So yes, I do 30–40% of my cases are done digitally with iCam or Shining 3D or for whatever technology that we have. But I would never give up this technique with the smart denture conversion because it is the fastest technique. And until digital catches up to the speed, this technique is going to be around. So we really enjoy doing this. So this course is going to happen in Las Vegas this year with Brandon and I, August 13th to August 16th. It's a 3-day course with 31 CE credits. And Mike PIKOS and I are going to be there with Brandon and Phil Hedger and Dr. Basma from University of Alabama is a periodontist. So I really hope to see some of you there.
I think, and I mean, obviously, I'm a little bit biased towards this course because we're using Smart Denture Conversions, but I think this is one of the most fun courses for full arch fixed that's out there. You know, you've got Mike PIKOS lecturing on surgery and Safa teaching surgery, and just the amazing results that Safa gets. It's worth coming to see. But then also being able to place your own implants, place your own multi-unit abutments, and see the impact that those decisions that you made have on your prosthesis. That is what makes you a better surgeon, is like observing the effect of your surgical decisions on the prosthesis. So it's definitely worth looking into. We have
One
another
of the
webinar
questions
coming.
was, will you be doing this at Tampa courses? I think this is the first time that we're going to do this course in Las Vegas this year. I think then we're going to be going back. This is at the Zest facility. They partner up with the PIKOS Institute. They want us to do this course at the Zest facility. I hear it's a phenomenal facility. And so we are going to be doing it in Las Vegas this time in August. It's going to be hot, but Tampa is not any cooler either in August. So,
Yeah.
but then I think we're gonna be going back to Tampa after this one. But this time it's gonna be the first time that we're gonna be doing this course in Las Vegas.
We do have another webinar coming up at the end of this month, June 25th, and this one's going to be cool because over the last 5 years, I've been involved in some research projects where we've tested the combination of denture material and pickup material and conversion technique, and taking it to the Instron machine and just trying to come up with what is the best combination of pickup technique, denture material, and pickup material in order to have predictable provisional restorations that aren't going to be failing on you. So it's going to be a really cool one. We've got the residents, they're now graduated prosthodontists, but Dr. John Bender, Leela Brightman, and Sejal Jain will be presenting their research in breaking dentures. So I hope you can join us for that webinar. Follow us on Smart on X on Instagram, Facebook, and LinkedIn, and become a Smart on expert.
That's our favorite.
One of the questions was, can you bring your lab techs to this course? That's a question that you should have for the PIKOS Institute. I don't have the answer to that. I remember when we used to do these courses at Brandon's facility, Brandon used to sort of want the doctors to bring their technicians. But at the PIKOS Institute, I'm not really quite sure if that's possible. I suggest you sending an email to the PIKOS Institute, or at least when you sign up for the course, call them. They may be able to make an arrangement for you, but you do have to make that phone call. I think at the Zest facility, it may be possible for a higher fee. I think that could be because it's such a big facility. And I think it's a great idea if you could bring your technician. It's a fantastic idea because it creates this wonderful relationship and understanding between the technician and the doctor.
Absolutely.
Now
Totally.
we do have some questions. I know we need to get to some of those. I want to make a quick couple of notes here. One is that, as you can see on this slide here, we are offering 15% off of Smart Denture Conversions. This is specifically to webinar attendees. using that discount code, you can get 15% off all Smart Denture Conversion products through the end of June. Now that includes SDC 1.0 and 2.0. So it's a pretty awesome deal. And that's at smartonx.com. I know there's a question that we've been asked a few times. Yes, we are providing a recording of this webinar to all who signed up and registered for the webinar. This will be sent out in an email. To that point, we've had a lot of new things announced today. This is, in a way, for lack of a better term, almost a soft launch of SDC 2.0. And by that, I mean we're making it known to a smaller audience today, but it's going to be more widely publicized to everyone in the coming days and weeks. And so that's why we'd ask you to please follow our social media. And for those who are not aware, because we've rebranded to Smart on X, we have some older Smart Denture Conversions social media channels that are being made private or eventually shut down. So please follow us on Smart on X and sign up for our newsletter so that we can make sure you are made aware of all the availability of these products. Most of these products are already on our website, but we are still building bundles and kits, and a lot of the things you've seen with SDC 1.0, we're still putting those together. So please follow along for all those details. With all that said, I know there's a lot of questions, and I want to make sure we get to them. So let's jump in real quick. We had
Cameron, I think I answered majority of the question.
I think there were a bunch in the chat, but there were a bunch in the Q&A.
Oh, okay.
So the Pterygoid implant pickup, someone asked, how is that going? Did we address that?
As many of you know, I place a lot of pterygoids. And I've never had a problem with pterygoids pickup. I think the one suggestion that I would say is that don't place your pterygoids too deep and choose a shallow multi-unit, and then have an abundant amount of soft tissue. You kind of have to gauge once you do your osteotomy, you place your implant, approximate the tissues for closure, and then make a decision. If you have a very thick soft tissue, a lot of soft tissue, then use a taller multi-unit. If you have shallow soft tissue, use a thinner multi-unit. And also, Brandon can add to this, is that the Smart Denture Conversion tie bases come in two different heights. They come in a 4mm height and they come in a 6mm height. For pterygoid, for certain patients where they have a lot of thick biotypes in the posterior, I have found myself asking for the 6mm. And particularly when you have the pre-coated on top of that, now it's like 8mm. So that's seldom a problem.
Yeah, so that's a very good point, Dr. Safa. That is the reason why SDC 1.0 will never go away. You want to maintain the ability to choose to use just a normal temp cylinder, a tall 15mm temp cylinder, and you can cut that down to whatever custom height you want for whatever clinical indication you may have. Most often you won't need to do that, but there are times when you might need to do it. So it's good to have the separable fastener available for those rare cases. But the majority of cases, just that standard 5mm tall tie base is going to be all you need.
Awesome. Why not do your pickup before closing the flap?
So I do. That's my preference. Dr. Safa, why do you choose to do closed pickup?
So that's a good question because, for the longest time before I had an associate prosthodontist and before I had other maxillofacial surgeons, I used to have to do everything on my own. And so I was needed on the floor. I was needed for patients that had had arches in the previous days. And so I needed to get in, do my surgery, close, and then go see some patients. And while the anesthesia team and the surgical team was getting the patient ready and they were taking their bathroom breaks or whatever, I would come do the conversion and then I would leave again. And also, I pay a lot of money for my anesthesiologist because I want my patients to have a beautiful experience. And so I didn't want to stop surgery to come and do conversion in the middle of surgery and then pay my anesthesiologist a lot of money, a lot of money per hour. And so I wanted to finish the surgery and dismiss my anesthesiologist to reduce the overhead of the practice. And so for me, putting the implants, putting the tie bases, putting the sutures, and leaving the room and dismissing my anesthesiologist was very important from a cost effective and also from efficiency in my practice. However, I know you and Dr. Mikhail Lindman in Kansas City, you guys do the open flap technique where after the implants are placed, multi-units are placed, and the tie bases have been placed, the surgeon steps aside, Brandon Kofford comes in, does his pickup, and says to the surgeon, okay, you may carry on. And then the surgeon carries on and puts the sutures in. By the time he's done suturing, the advantage with Brandon's technique with the open flap is that the prosthesis is almost essentially done. And so Brandon comes in, the surgeon is leaving, and then Brandon comes in and puts the prosthesis in and screws it in. And a lot of these patients are dismissed right after surgery. How beautiful is that? So it really kind of depends on your workflow and your technique and the way you are. Brandon's workflow and setup is completely different than mine. Brandon runs a business and is a clinician at the same time. And so he is in and out of offices, and he does things differently. He has relationships with maxillofacial surgeons. I'm a surgical prosthodontist. I do my own surgery and my own restorative. And so again, it really kind of depends on the workflow that you employ. Both techniques work very well. Both of them have their advantages and disadvantages.
That's right. That's perfectly said.
Awesome.
So yeah, I was going to say the advantage of my open flap technique is I am not usually the surgeon on these cases. So I'm going into my surgeon's office and I'm waiting around until we're ready to do the pickup. And so I've taken time off from my practice, and the least that the surgeon can do to respect the sacrifice that I'm making is to step away for 10, 15 minutes, allow me to do my pickup, and then he comes back in and he sutures. We also have an anesthesiologist coming in to do the sedation, but we pass that sedation or that anesthesiology fee on to the patient. So to us, it doesn't affect our profitability, whether we're doing it open flap or closed flap from the anesthesia perspective. But that's a very good point, and that's something to consider. And that's why it makes sense for Safa to do the closed flap.
Mm.
So another question: if the abutments get covered with blood or saliva, do you have to clean them with something to ensure a good bond and pickup?
That's the great thing about PMMA.
Right. You could do it with the PMMA, and you could take a little bit of PMMA and sort of pre-coat them again with some acrylic, but you may be getting some monomer into an open flap or whatever. Honestly, I've done thousands of these. Never ever has blood become an issue because heme is not sort of hydrophobic in the sense that it's not going to stop from that exothermic reaction from happening. So it's nicer if it's completely off, but if you have a little bit of blood over your tie base, do not worry. It's not going to prevent, because that exothermic reaction is so robust that the bond happens whether there's heme on there or not. And heme is not Vaseline, right? So it's a completely different. So yes, you could take a little bit of 2x2 or 4x4 and wet it in some saline and just kind of go there and just kind of get the heme off, but don't make it a big deal because I've never had blood become a reason why a tie base is not picked up.
Yeah, and that's actually one of the nice things about this pre-coated version of the tie base. The polycarbonate, like the heme, will wipe off very, very easily. When we pre-coat with acrylic, salt and pepper technique, then that PMMA is pretty rough and not porous, it's just rough, right? And so the heme doesn't wipe off very well. You can rinse it off, but it doesn't wipe off well. With the polycarbonate, it wipes off very, very easily. But the pickup material, PMMA, is hydrophilic. The composite-based materials like chairside and easy pickup and stellar, those are hydrophobic. And so the heme will have an impact on your pickup if, I mean, obviously if you're using the pre-coated tie bases, you're not going to pick them up because the material doesn't bond to it. But yeah, heme is an issue for those hydrophobic materials, but PMMA, hydrophilic, it's great, not an issue.
Awesome. I think this is referring to the technique you brought up earlier, Dr. Kofford. How do you remove the peak cap easier? And I
Oh
want
yeah,
to
so
add that we are releasing a video of Dr. Kofford in the next few days, showing the entire SDC 2.0 workflow, and in that he does show this.
well, and actually, we're going to be posting a video of my visit to Dr. Egbert's office in April, where it's actually Dr. Egbert showing me how to do this, and it's amazing. So, but it's the clean out drill can fit into an NSK handpiece, and then you just turn your NSK handpiece down to, I think it's like 4,000 RPM, and you just go down in there. It grabs onto that peak head and pulls it right out. I was blown away when I saw him do that. So we'll be posting that video to our social media soon.
Great. Would sandblasting the plastic sleeve, I think they mean the polycarbonate, be of added advantage before chairside pickup?
I haven't tried it, haven't needed it, so I don't know. You know, it might have an added benefit theoretically, and to benchtop studies it might, but clinically I haven't found it to be necessary. But if you like to use your sandblaster, I'm not going to stop you.
Awesome. Someone asked, can you get the new cylinders without the coating and use peak screws?
Well, yeah, so that's I guess you're asking, can you get our tie base 2.0 and use our separable fastener 1.0? We haven't thought about doing that, but if that's something that would be of interest, I can see the advantage to the having that polished collar. So sure, we can make that available on the website.
Yeah, we can look into that. Someone asked, can you explain how you do the no post pre-coated tie bases conversion? I want to know if it's getting cleared the inside portion of the tie bases with the same drills for smart conversion.
Yeah, yeah. The drill out's the exact same. It just is a little bit easier because you don't have anything resting on the screw seat in the tie base. I think did we do a video, Cameron, of the no threaded post?
Yeah, we have both versions that we
Okay.
made videos for.
Okay, and so we'll be making those available on the website.
Right. Have you noticed passivity issues due to the shrinkage rate of the PMMA?
So I personally have not. Safa, have you?
Yeah, and we have a common friend, Dr. Mark Andrewis, in New York, who initially, when we introduced him to the Smart Denture Conversion, this guy, I make fun of him. He's a passive fit freak. He spends time, hours and hours trying to get his stuff passive. And initially, when we introduced him to the Smart Denture Conversion, he's like, "No, this is not passive fit." You remember that, Brandon? And it was
I
hilarious
do.
for Brandon and I, because we've been doing thousands and thousands of arches without any problems. And then I think 3 years passed by, and now I see him using Smart Denture Conversion. And I ran into him the other day at a conference, and I said, "What happened? I thought you thought these are not passive." And he looked at me with a smirk and he says, we realize that it's not clinically significant. As you know, fit can be very off, right? The fit can be off up to 100 microns. And of course, digital with photogrammetry has tried to bridge that gap. But really, how clinically significant is it, particularly with the use of multi-units? So while I agree that for your permanent definitive prosthesis, you should have a very good fit, well, I agree 100%. You should try to reduce that gap as much as possible. But during the healing phase, it is not clinically significant. Is there some shrinkage and less passive fit with smart denture? Yes, maybe I don't know how you would even quantify it and understand how much that is. Of course, acrylic shrinks. I mean, that is just common knowledge. But is it clinically significant to the point that it causes a problem for the patient, or it creates a problem for your digital workflow, or it creates a problem for your restorative workflow? Absolutely not. Absolutely not. And it doesn't create any issues at all.
So, and I will say this, and I just did this today in a healed ridge. I was making a new conversion prosthesis, and I chose to do it in a two-step approach where I relined the intaglio with the acrylic. Put it in place against the maxillary prosthesis, and then I closed the patient in to it. And then when the material was doughy, I opened the patient up, and I did that a couple times. And then let the acrylic, the bulk of acrylic, set up outside of the mouth. And then I came back and picked up the cylinders with a very small amount of acrylic. I did that not necessarily for passivity, but in a healed ridge, the patient's not anesthetized, and the PMMA puts out heat, so I don't want there to be a lot of bulk of acrylic setting up in the mouth. So that's why I do it in a healed ridge that way. However, it also reduces the amount or the effect of polymerization shrinkage because the bulk is being set up outside of the mouth, and then you're picking up the tie bases with a very small amount of acrylic. It's the same concept as when we would do those verification jigs, and you section it and then you lute it back together with a very small amount of acrylic because it reduces the effect of the polymerization shrinkage, or it limits the effect of the polymerization shrinkage. So I haven't found it to be a clinical issue. Safa agrees. He hasn't found it to be much of a clinical issue. However, for those of you who are very concerned about the effect of polymerization shrinkage, that doesn't mean you can't do smart denture conversions. It just means you do it in a two-step approach. It's still very quick. That PMMA sets up in 3 minutes. So you do that first approach, that reline, 3 minutes. Great. Maybe take 2 minutes in the laboratory to open up the wells just a little bit and come back and reline it another 3 minutes. So your pickup time was a total of 8 minutes. And then you've reduced the amount of polymerization shrinkage. Great.
We need to wrap up, but we do have 2 more questions that I want to get to. Why would one select the traditional breakaway screw versus the new integrated thread?
I would say it's because of the press-on cap. Let me change that. The press-on cap, as well as perhaps the drill out procedure, with the integral screw, you have to take like a wax instrument or a periosseal elevator and just lop off the polycarbonate threaded portion sticking through the tie base, and then drill through it. It's very easy to do, but it's one reason. I mean, Saf is always telling me, Brandon, you have to do it this way. Doctors aren't going to want to do this X, Y, and Z or the other. In fact, Safa doesn't even like the stems on our pre-coated parts because you have to stabilize the tie base with one hand and then break it off. So he says, that's stupid, Brandon. Don't do that. And I said, Safa, if you don't like it, just break it off before you put it in the mouth. He says, oh, yeah, I guess you could do that.
Yeah.
So,
Yeah,
I mean,
and one
everybody
point
just,
about the smart the press-on caps. I like the press-on caps for a couple of reasons. I've been doing implants for a long time, for about 15 years. And I can't tell you how many times training other surgeons I've seen um, assistants or doctors put healing caps at a offset angle and lock up the healing caps over to the implants and cause a jam between the healing cap metal component and the multi-unit, to the point that if the doctor is not around, let's say a junior doctor or an assistant is coming back, and they try to remove the healing caps, either the healing cap is stripped or they end up reversing the implant, especially if the implant didn't have a torque. So I've seen problems happen chairside with pressing healing caps after surgery. And so for me, the press-on cap, I love it because as soon as the conversion is done, it just gets press fitted in, and then reversing it because it's made out of PEEK is just so easy. Where if you're using metal versus metal, sometimes putting your healing caps on, sometimes you could really jam and cause problems with the implants. And then now you're there till 7 p.m. trying to figure out how to fix this problem. So press on, for me, the press on cap stays.
Yeah, and I love the press-on cap too, just for the efficiency of placing it. I hate
Yeah.
screwing on healing abutments after the tissue's
Oh,
all
yeah.
sutured up. So I love the press-on caps. But Safa, what do you not love about the press-on cap? And Nick Egbert, you can chime in the chat if you're still here. What do you
Well, I
not
think
love
they're,
about the press-on cap?
yeah, I think their emergence profile is a little bit too narrow. And so
Right.
sometimes the tissue, so especially if, if you haven't done the right reduction, the right tissue resection and right bone reduction, sometimes when you come back and you try to remove them, either you can't grab them or sometimes they just fall over the place. So we've asked Brandon for the longest time since 1969 to create these press-on caps that have a little bit of a flare to them and they're a little bit taller. So when you come back to put the prosthesis on, then it's very easy. When you remove them, the tissue is pried open. And so you don't get tissue impingement and as you try to put the prosthesis in.
And so now you know what the subject of SDC 3.0 will be.
Yeah, exactly.
So that is in the pipeline of the innovations that we'll be bringing to the Smart Denture Conversions components. Is just, all of these projects, they do take a lot of effort, and just working through the regulatory and everything that we have to do, we have to prioritize, well, which one's going to make the biggest impact. And so getting these pre-coated tie bases was a bigger deal. And now that we've freed that up, the press-on cap contours are going to be fattened up.
Okay. So we're way past time.
I'm
We do
sorry.
no, it's okay. You guys are passionate about what you do, and that's awesome. We do have 2 more questions. Do you guys want to take those questions, or should we wrap it up?
I mean, I figured we can take the question, and then people, if they're still here, they can hang around if they want to, they can leave if they don't want to, but at least we've got it videotaped and people can hear the answers to their questions.
All right. Have you had issues with low torque implants pulling out?
I
Um,
have not.
yeah, neither have I. Quite honestly, and I've heard this question come up in, um, I would say take the PIKOS course, and we will show you how that should never happen. Um, I, I've been doing implants for a long time. I do implants every day. The last time that I inserted an implant with less than 45 newton centimeters of torque, maybe at least 32. Can't remember when that was or where that was. There's always way to get stability. You just need to know your anatomy and need to understand your fixtures and how to do your osteotomy and your fixation. So that's a surgical question, and I think the PIKOS Institute would be the best place for you to answer that question.
And that's the honest to goodness truth. I will also say that the pull-out force of a separable fastener is about 2 to 3 pounds. And so I always tell people who have that question, aren't you worried about pulling an implant out? I say, no, I'm not. And if it does happen, you're welcome, because that's an implant that you should not load.
Yeah.
All right, last one. When using the 2-stage pickup, did you have a problem with the dough grabbing the polycarbonate cylinder?
Well, no. So there's a technique for doing that. And before you put the prosthesis in the mouth and start forming it, you wait till it gets to the doughy stage, and then you spray it with water, and then you place it against the opposing dentition. You rotate the patient into, I'm assuming this is a mandibular arch. You rotate the patient into the intaglio, you open them up, and you just do that a couple times, and it won't stick to that material. So there's a technique to it, but if you follow that technique, then it won't be an issue.
Fantastic. I
I
think
think we need to do a video of that, Cameron.
yeah, sounds good. We like making videos. That's not a problem. So Well, thank you everyone for joining us. I think we got to all the questions. If we missed any, we apologize. Please send them to us on social media, send us an email, and we can make some other videos, short videos to answer your questions. We'd be happy to do that. I want to say thank you to Dr. Kofford and many thanks to Dr. Safa for joining us tonight. Thank you all for being here, and especially those of you who stuck around to the end. So have a great night. We will be sending out a recording in the next couple days.
All right.
Yeah,
Thanks,
thank
Cameron.
you guys. Have a nice evening. Thank you, Brandon. Thank you, Cameron.
Good to see you,
Take care.
Safa.
Bye-bye.
Bye.
Bye, Kimberly. Bye-bye. Bye-bye.